this control can help us in order to have a better target or destruction of the tissue. We can maybe have a better control of the system. What about the results? This is our initial series. We already treated more than 70 patients with focal therapy. We just selected the patient with the well-recognized indication. I mean PSA less than 10, lesion score less than 6, and then we have 48 patients. 85% of them will have an ontological and functional follow-up. As you can see on this slide, most of the patients didn't have any complication after this kind of treatment, because 81% of the patients didn't have any complication. 15% have minor complications with perineal pain or some or scrotal swelling, and 4% of them had, unfortunately, Clavian 3 complication. 3 of them had an urethral stricture, and 1 of them had rectourethral fistula, which was probably due to a bad needle placement, especially at the beginning of our experience. What about the ontological results? As you can see, 82% of the patients had negative biopsy at 1 year. 71% of the patients had negative biopsy, and 11% of the patients had negative biopsy at positive biopsy, at the opposite side of the treatment. What about the PSA? The PSA level dropped significantly after 3 months, and then reached a plateau that it kept, with a significant difference between the initial PSA, the pre-treatment PSA, and the post-treatment PSA. And regarding the functional results, we didn't have any significant differences in terms of urinary complication or sexual dysfunction. Regarding the sexual dysfunction, after 3 months, the patient had erectile dysfunction, significant erectile dysfunction, which will re-improve after 6 months, and after 6 months there is no more difference between the initial IIEF5 and the final IIEF5. Ban published also a huge series of 73 men who had a focal therapy, and he had the same conclusion as us. In his series, 78% of the patients had control biopsy, and only 17% of them had a positive biopsy in the treated area. And as you can see here, the PSA drops at 3 months, as we showed in our series. So cryotherapy is probably a good option for focal treatment, with a low rate of side effects and good control of the disease. The other option, which is a new one, is the photodynamic therapy, which is performed in a phase 3 trial. The principle is to use a photosensitizing drug that we injected via an intravenous administration, and we put some laser fiber in the prostate, and then there is an activation. After the activation of the light, they will produce the contact between the light and the drug in presence of oxygen, which produce very localized necrosis. You can see here, this is the transperineal approach, as like the cryotherapy. This is the laser that we use. We do a pre-treatment planning. Here is the area that we have to treat, and here, as you can see, there is a huge lesion, but the capsula is totally respected. A part of the capsula is totally respected. So what about the results? This is a clinical trial, as I told you, but the results are really encouraging, because we treated more than almost 100 patients, and we arrived to create a real lesion with the cancer destruction, because 80% of the patient had negative biopsy at the treated area without any significant side effect, because we didn't have any patient with urinary incontinence, and all of the patients who had a sexual function before treatment had the same sexual function after treatment. And the last option is the brachytherapy. Everybody knows the brachytherapy. This is the same principle that the whole gland treatment with a transperineal approach, and the radiotherapist will deliver 145 grays at the level of the cancer area. The difference between the focal therapy and the whole gland treatment is that they do, like with the other option, pre-treatment planning, and using the biopsy results and the MRI, and then they implanted the seeds in order to treat the area that they expected. What about a result? This is the early experience that we have. We did 21 focal implantation up to date without any urinary toxicity, without any rectal toxicity, and with some good results regarding the sexual function, because the patient reached the baseline sexual function that they have after 1 year. So these treatments are probably good treatment, but there are few limitations. So you know that prostate cancer is a multifocal treatment, and depending on the series, the author reported in between almost 70% of multifocality. We know that the prediction of low risk or unifocal or unilateral tumor is good with the devices which are available today, but not great. We cannot be sure that the lesion is unique and it's a low risk. We don't know the natural history of the untreated non-index cancer. We expect to treat the index lesion, but what about the other lesion, the multifocal lesion? And we don't know how to follow the patient. We don't know how to monitor the patient, how to manage them after treatment, and which important do we have to give to the PAC after treatment, and whatever. So this is a good technique, but nothing has been proved up to date. So in conclusion, we can say that there is today an over-datation and over-treatment of prostate cancer, which is a significant problem. That focal therapy is safe, it's probably a good option, but we cannot be sure, and we have to do probably more works and multicentric studies in order to have a better conclusion. One thing is sure, is that we have to rethink the approach that we have, the low volume, low risk prostate cancer. Thank you very much.
Muchas gracias, doctor Barret. Excelente conferencia. No sé si hay alguien que quisiera hacer algún comentario o alguna interrogante. Si no, pues como el doctor Barret tiene que coger un avión pronto, you are free to go. Thank you very much.